Hello, everyone. Nice to see everybody on the call. We will start shortly. If you can see and hear us, can you please just put a comment in the chat? This is my first time working with the webinar format, so we need just a minute or two to adjust. But if you can hear or see us, please either give a thumbs up or you can write a message in the chat. Perfect. I'm getting some thumbs up. Good afternoon. We can see and hear you. Perfect. We just figured out that with the webinar format, till I start the meeting, the presenters stay in this sort of green room. So now you guys should be hearing us and seeing us. Parfait. Bonjour, Benoit. All right. I think we can start. The recording has started. What we usually do, well, first of all, my name is Charlene Clark. I'm the project lead for the Mental Health and Addictions Work Group. The information sessions or the Lunch and Learns is the project that we launched at the end of 2024. So today we are welcoming you to attend the 20th information session with the University of Ottawa Heart Institute. Um, so the way that it usually works is that we invite partners to come and share important information on services that exist in hospital and in community. We usually record the sessions as we're doing today, and we will also put them on our YouTube channel later on. Uh, because we want to make things interactive as well, the first portion of the session today will be the presentation, and then the second half will be a Q&A. We usually stop the recording during the Q&A section, just so that in case people have, we don't encourage people to share sensitive or confidential information, but if there are some more targeted questions for our partners here, we usually want to give our partners the opportunity to ask those questions. So you will see that the recording is started. It will keep going. And once we reach the end of the presentation, I'll try my best to work it to close off the recording. I might have a bit of a hard time because, of course, this is my first time working with this format. I might just keep it extended and end the recording after the Q&A and then cut it right before it starts. We'll see how things go. But yes, again, thank you so much to our partners for hosting the sessions with us. I believe there's a Q&A button there as well. I don't know what I need to do to get it started, but we'll figure that out during the session. I will pass the mic off over to you, Joël.
Thank you so much, Charlene. Great work here. And then good afternoon, everyone. Il fait très froid dehors. It's very cold outside. I hope each of you have a warm cup of tea or coffee. The session will be in English, and I would like to say a special thanks to Erika and Bonnie for hosting this session. Thanks for taking the time for this presentation. So without further ado, Erika or Bonnie, may I ask you to take over from here.
Un gros merci, Joël et Charlene. Thank you for having us today. Bonnie and I have been talking with all the various health teams. As many of you know, the Heart Institute is not an actual member of any of the health teams in our region. We partner with all of them, though. So we, are making an effort to connect with our primary care and community care partners, and just to, share what's going on at the Heart Institute, what's available for everyone in the community, and to answer any questions and bring back to our teams anything that you have for us with respect to services, connections, clinics, activities, that sort of thing. So I'm going to start off, and then Bonnie is going to jump in. And again, to echo Joël and Charlene's comments, we're not as savvy either with the Q&A function in this webinar one. So if we don't see your hands, please feel free just to pipe up and interject and ask your question. We, do hope it's interactive, and we hope to have good discussion. So before we get started too, I just wanted to begin the presentation with a land acknowledgement. The University of Ottawa acknowledges the unceded traditional territory of the Algonquin and Anishinaabe and the people of the Algonquin and Anishinaabe Nation. We recognize all Indigenous people in the region from all nations across Canada who have also made Ottawa their home. We acknowledge the traditional knowledge keepers, both young and old, and we honor their courageous leaders, past, present, and future. We dedicate ourselves to moving forward in the spirit of partnership and reconciliation. Together, we take responsibility for the heart health of all peoples in the region. So again, I'm Erika MacPhee, and I'm the VP of Clinical Operations here at the Heart Institute. And Bonnie Quillen is our Clinical Director of Prevention and Rehab. And between the two of us in our longstanding careers at the Heart Institute, we've held almost every single nursing and leadership positions that are available at the Heart Institute. So collectively, we're well over 60 years of experience at the Heart Institute. So the objectives today is really to review and discuss the key cardiovascular programs, briefly highlight our mobile screening programs, both our Million Hearts Initiative and the Valvular Heart Disease, and introduce the Prevention and Wellness Center. So many of you may have been in attendance or heard or seen various presentations or iterations of the Heart Institute's new strategic plan. We launched it last fall in September. It's Your Heart, Your Institute, Our Future Together. And our strategic priorities are to make sure that your heart is in the right place, and that the care is in the heart of our community, and the heart of innovation and discovery is at forefront of our mission as well. We want to leverage data, AI, and technology, but make sure we do that with a human touch. We have excellent and established collaborations with the 16 hospitals in the Champlain region, but now we're really focusing on extending our collaboration and connections with all the community partners in addition to the community hospitals. So just to highlight some of our key cardiovascular programs, I want to highlight what we think is of value and interest, and we've also seen a lot of referrals to from the community: our guideline-directed medical therapy clinic, our acute cardiac triage unit, and our mobile screening program. So our GDMT clinic has been running now for about 18 months. So it's an evidence-based program that aims to assist those who have heart failure and reduced ejection fraction to help them achieve their optimal heart failure treatment. So we want to ensure that all these patients are on the appropriate medication for them, and that they keep on these medications and that they're titrated and adjusted appropriately for each individual. So patients are typically seen at the beginning of this clinic, and then once after maximal therapeutic optimization, there's a nurse-led assistance with medical optimization in between. So we have medical directives for our clinicians that work in this clinic, and they're able to monitor and adjust medication, and it's all under the medical directives that have been initiated by our medical team. So the goal of the clinic is to optimize treatment in 3 months after, and then the patient is transitioned back to their referring physician or to another cardiac specialist as clinically indicated. So how is this available to you? We do have a referral form on our website, and I'm able to send it to Joelle and Charlene after, and they can share it with you broadly. I realize it's really small on this, but it is available on the ottawaheart.ca website in the referrals section. So the acute cardiac triage unit came to existence when the Ottawa Hospital Civic Campus began its quest to build its new building down the street. And we recognized that we needed to have a mechanism on the site of the Heart Institute once the Civic Hospital moves down the street to provide urgent care for patients known to the Heart Institute. So the patients come to the emergency room at the Civic Campus because the Heart Institute doesn't have one. As well, too, we get patients admitted to the Heart Institute from our ambulatory care clinics and our medical imaging area. A lot of times we have difficulty and challenges with beds. So this Act 2 provides a landing place for patients to be monitored and cared for, either while they're waiting for a bed or if they need just a few more hours of observation and treatment. So typically, patients are sent to the emergency room for many cardiac-related concerns that could be solved with a little more assessment and temporary monitoring and testing. And then, as I mentioned, they could be just waiting here for our beds. Now, patients are known to the Heart Institute, so we don't take anyone off the street. So they would have had to have been a patient of some type at the Heart Institute to be seen in this acute cardiac triage unit. So a brand new person experiencing chest pain for the first time would still have to go through the typical referral process, either go visiting Emerge to their family physician or a walk-in clinic. So what this acute cardiac triage unit too has done is improved access of timely care for cardiac patients. So it's really improved patient-centered care. It's also reduced emergency room avoidance and hospital admission significantly. Patient satisfaction is tremendous. We have better patient outcomes because we're intervening in a more timely manner. We've reduced the burden on the emergency rooms. And then we are also triaging to Emerge appropriately. So typically patients, they all have access to a 24/7 phone number to call the nursing coordinator to discuss their symptoms and how they're feeling. And if it's something that's not, we're able to assess and address over the phone. In the past, we tell them to go to their emergency or to contact their family physician. Now, because we have this Act 2, it's open Monday to Friday. We've extended hours last April until 11:30 at night. So it's open 8 o'clock in the morning, and we're able to bring the patients into the clinic. In June, we hit seeing 300 patients a month. And since it's opening in March of 2024, we've seen over 3,000 patients. We've also had about 17 patients of these 3,000 only having to be sent to Emerge, and they were with non-cardiac related issues. So it's a wonderful clinic. It's a wonderful opportunity. And, you know, the staff is amazing, and the physicians as well have really, really embraced this. And, you know, there have been community physicians that, you know, when they have a patient who post procedures, sees them in follow-up, and they are not progressing as they should, they can call the Act 2 and have that patient come to the Act 2 and see the nurse and the cardiologist. The mobile screening program is also in full force at the Heart Institute, and that started over 3 years ago. So heart valve disease is the next epidemic in cardiovascular disease. So we are feel very strongly that it is an underdiagnosed and underscreened, and that there are many people with valvular heart disease that don't know they have valvular heart disease. So when we started, and we continue to, we're screening patients that are over 65 years of age. We started with underserved populations. So we were going to the housing, Ottawa community housing and aging in place buildings. We worked with public health. We worked with various ethnic groups. We went to rural areas, and we also went to Indigenous communities as well. We have a booking system online. So when we did make connections in these communities and these areas to set up our mobile valve screening clinic, we send out information to the community with QR codes for booking, and people in the area are able to book an appointment, and then they come to the clinic and they get screened. So not only do we do a point of care echocardiogram, but there's point of care blood work done, as well as baseline ECG with the pocket ECG where you put your thumbs on. It's called a Cardia device. And then we also do some risk factor assessments as well. We do look in, and this is feedback we got from the community, in clinical viewer to make sure patients have not had blood work within the last year. So if they've already had blood work within the last year, we do not repeat the point of care. We did notice that there were people, when they saw we were set up in these various clinics, would come and they would want to repeat blood work. And we realized that was a huge burden because the blood work is flagged back to the family physician. And we realized that was really unnecessary testing and also a burden on your offices and systems because they've already had their blood work and were being followed for their diabetes or their hyperlipidemia. So thank you for that feedback because we hope we've addressed some of that added burden of sending repeat test results back to the offices. So when we have a clinic, we have a nurse and a sonographer go, and a clerk out to these mobile clinics to do the screening. And typically they can screen about 20 to 25 patients in a day. There is no government funding for this. This is all funded through philanthropy at the Heart Institute, as well as our own operation of funding at the Heart Institute. Just to give you a little snapshot of some data. So what we're seeing is we're identifying a small percentage of valvular abnormalities. And as well, we're identifying about 15 to 20% new cardiovascular risk factors. This clinic has also identified some severe abnormalities. One example is a patient was identified with a severe aortic aneurysm and had emergency surgery within 48 hours. So, we do pick up odd, very critical things like that as well. If there is valvular abnormality, they're referred right away to a cardiologist, and a cardiologist will follow them. So the clinic has been growing in its volumes and in popularity. We have many communities reaching out to us. We're working now outside of the boundaries of Ottawa with the regional hospitals who are connecting with their health teams to set up clinics in areas that they've identified as a need for valvular screening. So right now we're doing about 36 clinics a quarter. The target is to do clinics 5 days a week. And again, here just on the side, what I've already touched on briefly was who we're screening. We are now partnering with our cardiac rehab and prevention program, which Bonnie will touch on, as well as trying to incorporate our 1 million heart screening, which is risk factor screening for those 64 and under. So the next steps, as I said, they want to go 5 days a week. We'd love to onboard a nurse practitioner, not only to help with the ultrasound follow-up and notes, but also for those patients that come to us that are unattached, and for those with uncontrolled cardiovascular risk factors, and to prescribe some guideline-directed medical therapy and make the necessary referrals. And we're hoping that would reduce a significant burden on the community partners. We want to as well continue to expand our reach, and we are in the process of looking at having an actual vehicle to transport all of our equipment and staff and have not to have to rely on bricks and mortar. But we do realize that we live in Canada, and this cold does not really, allow for us to have a year-round mobile type units. So we still need to rely on bricks and mortar to host our clinics in. Okay, so now I'm going to pass it over to Bonnie.
Awesome. Thanks very much, Erika. And thank you all for attending today. So just switching gears to primary prevention, which is the other half of our cardiac rehab division. So this Cardio Prevent program has been around for quite a while, but we've had it undergo a huge remodeling, I guess I'd say, in the last year or so. So this program will screen anyone from the age of 18 and older who do not have a history of any cardiovascular disease. For cardiovascular risk factors, there's a lot of health coaching that goes on with this, and really helping patients lead a much more heart-healthy lifestyle. We also look to engage these participants with community partners, for example, the Ottawa Diabetes Program, Smoking Cessations Program. So we're not reinventing the wheel, but we're really moving people where they need to go to prevent them from developing disease in the future. So this program was developed after the Cardio Prevent, so it's an arm of it, the postpartum program, and we get a lot of referrals actually from the TOH high-risk clinic. These patients are referred typically about 6 months after they're discharged from the high-risk clinic at TOH, and have the same type of risk factor screening and interventions that we'd have in Cardio Prevent. So what we're looking at is, really the same thing that we do in cardiac rehab for secondary prevention, really. So looking at complete risk factor screening, looking at all the typical blood panels and assessments that we would be doing for any patient, and to give us an idea of their risk and providing them with the appropriate supports. So that's sort of an algorithm of what happens when patients come into the program. First of all, you do need to have a referral from a primary care provider to get into the Cardio Prevent program. So after that initial referral, which can be done through, on our website, we have the referral, and also even through Epic. They're booked a consult with a nurse or a kinesiologist. Those are the two types of regulated providers that we have within the program. They do an intake typical to what we would do in cardiac rehab.
Just going to interrupt
And
folks to pause or sorry, to mute their mics, please, if you're not presenting.
Yes, please mute your microphones. Thank you.
And then they have follow-up really based on specific patient needs. So it's very targeted to the number of visits that the patient requires. A very similar change that we made recently in cardiac rehab as well. Instead of sort of putting patients into certain timeframes and blocks that really don't fit what they need. A lot of the programming has moved to group sessions, and that's been beneficial in that it's obviously more efficient to be able to provide group education, but it also then allows participants to actually have the education provided to them by the provider of choice. For example, having a dietitian lead nutrition classes as opposed to having the nurse or the kinesiologist do one-to-one. So we do a lot of that. We've also developed a national webinar as well. There is an arm of these patients as well that is seen in our cardiometabolic clinic by Dr. Heshka, who's an internist with us. So she'll see high-risk participants with uncontrolled risk factors, and she will see all the postpartum patients as well. So patient enrollment, one of the things we did was remove our cap, and with the adjustments that we've made to programming, it's really opened up our referrals and our capacity, our ability to really lower our wait time for these patients to be seen, and seen a tremendous increase in volume as well. A few other things, we've moved completely onto Epic in the last 8 months, which is great. So all providers can have access to the notes that are seen, so it allows for better collaboration. And there's an awful lot of outreach that we're doing within the communities. We're going out and doing presentations to community health centers, to marginalized groups, even retirement homes, seniors clubs, etc., really to get the word out about our program and just about the awareness of cardiovascular risk screening and the importance of it. We've also integrated a lot of the resources between the primary and secondary teams so that it is a greater use of our resources, and it really provides better patient care at the end of the day. Again, you have the clinical psychologist that's leading the mental health programs for both groups now, the dietitian I've mentioned, that kind of thing. some quality projects that this team has been focusing on. And one group at the top is targeting patients who come in for an angiogram, for example, and are diagnosed with non-cardiac, blockages really that are under 30%. So often what those patients hear is a message of, you're good to go. You don't have to worry, that kind of thing. But meanwhile, they have significant risk factors that could lead them to coming back in the future. So we've done some education with the cath lab teams, and we are referring more of these patients to CardioPrevent to really help them with risk factor management. We are also targeting family members of our patients. So these are all high-risk folks, right? And they are a captive audience when we're doing our patient and family education classes. So again, really getting the message out that CardioPrevent is for them as well. A new support program as well that we've started with collaborating with our patient partners. So we've developed a program where we are looking at peer support for women and really targeting to what the patient disease is. So for example, if you had a SCAD patient, you're going to partner them up with a SCAD peer support, etc. And we're also starting this with patients on the surgical wait list at home. So these patients are very anxious, and along with all the education they now get this great support from another past patient who really can provide them with the kind of support that often healthcare providers can't. The cardiometabolic clinic is run by Dr. Heshka. So as I mentioned earlier, she will see those patients with uncontrolled risk factors requiring more medical optimization. And an example would be patient referred to us from postpartum, for example, without a family physician having uncontrolled risk factors. So that's generally the ARM patients that we see in this particular clinic. So that's our CardioPrevent team. They are small but mighty group. So what's ahead? Well, you probably have already heard about the Million Hearts. This is a program that was part of our strategic plan rollout, and this was started in September as a pilot. So we are looking to screen anyone without known cardiovascular disease over the age of 18 for cardiovascular risk factors. So we started with our staff, and we started with them in September, and the uptake has been amazing. We're starting to screen family members now of staff as well. So this involves a shortened version of the screening survey. And patients, we use point-of-care testing, similar to what the mobile valve clinic uses that Erika referred to earlier for diet, for the A1C and the lipid profile. And then participants are provided with risk factor profile and also interventions and referrals as they need in education. So the next steps with this program is going out into the community, and February the 10th, we are going to Parliament Hill to screen the MPs. So very appropriate. It is Heart Month, and this is in partnership with CCS, where we're trying to raise awareness of the importance of screening for risk factors across Canada. Here they're bringing in MPs from both Eastern and Western Canada, so it's not just the Central Canada folks that will be screening. So this will be one of our first trips out. We also have the HeartWise program as well. That's a well-known program for many, many years. So this provides safe exercise for patients with really any chronic disease in the community. So we provide the training, the modules, and the support for this programs in our communities. And it's actually used across Canada, many centers now. So thank you. Thank you very much.
So thank you. So that's our spiel. So now we'd love to open it up and answer any questions you may have.
Absolutely. So Marilou tested out the Q&A section, it seems to be working, but I think we can do it the old school way. If you'd like to type in your questions in the chat or unmute yourself as well, we are here to answer any questions you may have. I'm also going to stop the recording in just 1 second.
And thank you for posting it, Mary Lou, the 100 hertz, 1 million